Great. Well, thank you, David Shidlow, for the introduction. It's really a privilege to be here. This conference has been fascinating for me as a surgeon. I don't spend as much time in some of the nitty-gritty details that I've heard today, and it's been really enlightening to see how interconnected all of this is, and going through all the cellular implications of all the congenital heart disease that we treat, both within the heterotaxy spectrum and outside the heterotaxy spectrum. It's phenomenal to see how much work has been done, and so interesting to think of how much work can be done to sort of link all of these elements together. So it's been really terrific. So I'm going to sort of do two talks back to back, essentially. One talking about our efforts in really single ventricle heart disease and how we're using 3D modeling and simulation to really make our Fontan patients as good as they can be for as long as they can be. And then I'm going to talk about our efforts in biventricular repair, particularly in heterotaxy patients. We have a phenomenal biventricular repair program at Boston Children's, headed by Ram Amani, who's in Denmark this week giving a talk. So I'm going to cover those elements, but several of us work in both the complex single ventricle patients and the complex biventricular patients, and so much great work is being done in that area. Just some disclosures. We get some software help from many companies, and we'll talk a lot about off-label use. So for the last 8 years, we've built at Boston Children's a three-dimensional modeling program that is focused on building patient-specific 3D models for preoperative planning and intraoperative guidance. These models are made from CT scans or MRIs. We make them in a way that you can take the different elements of the heart apart, and our individual clinicians can do this on a web-based viewer. So you can look inside the heart, outside the heart, any combination of views. And it's totally transformed how we approach these complex patients, and it's really enabled us to take huge steps forwards, which you'll see in how we prepare, plan for, and execute these complex operations. The goal is to make things very repeatable, very predictable, and have really quality outcomes for all of these complex patients. I'll share with you how we do this. In addition to seeing these beautiful and exquisite 3D models, we use them as a platform for virtual surgery, and I'll show you several examples of that, where we plan everything we're going to do in silico, and then take those plans in the operating room. And we also use flow simulation, which has been a total game changer. If I step away from the mic and you can't hear me, please wave. So I'm going to start with sort of the complex end and work backwards. We're going to talk about the use of computer flow simulation to help inform how we manage these complex Fontan patients. And this is, computer flow simulation is a standard engineering technique that's used in airplane and automotive industry. It is used very, very widely, and it's been used for decades there. So we have really taken that exact same software, that exact same approach, and applied it to these patients with congenital heart disease. A few centers have done it over the years, and we have really scaled up to a tremendous degree. So we use this in complex Fontan patients to understand the best surgical option. And with the flow simulation, we can predict both the overall flow balance to the lungs, as well as specifically the liver flow balance, the hepatic venous return to both lungs. We can also estimate the energy loss across the Fontan pathway, all elements that are really important to being a good Fontan. And so we're going to talk about our effort to not only develop but also validate this approach. As engineers, you want to be able to say what you were going to, say what happened actually happened. And so we've taken great lengths to show that this is really accurate in predicting what's going to happen in our patients. So essentially what we do is we take the 3D model. On the computer, we plan the different surgical options. We use the cath and MRI data to really create a mathematical model of the patient, their flows, their pulmonary vascular resistance, all of the elements. And then we do a simulation on the computer where we're saying this is exactly what we expect is going to be post-op. Not a maybe, but based upon their physiology, we're trying to make very clear predictions. And then we do post-op MRI to understand how accurate we were. We use these models every day in the operating room for intraoperative guidance. We have the models up on a screen next to the surgeon. For those of you with children, you will recognize that's a Nintendo Switch controller, which we've reprogrammed to use as a mouse. and we use it to really guide the surgery and, and allow us as surgeons to do the operation exactly as we had planned. And so we've been doing this computational fluid dynamics now for 7 or 8 years, and we recently presented earlier this year the MRI validation of the CFD predicted flows. And, and the most direct measurement we can do from MRI is the overall flow balance, so the predicted flow to the right lung and the left lung. And in our cohort, the flow simulation, the computational fluid dynamics predicted 49 plus or minus 8%. The MRI measured 47.5%, and the percentage based on each patient was 7% plus or minus 4.5%. So with 93% accuracy, we're able to predict the flow balance in these patients after surgery. So this has really been a wonderful validation of this approach. We can also predict the hepatic flow variation. This cannot be directly measured by MRI post-op, but we've done simulations on the post-op MRI and show about a 16% variation from what we predicted. In the world of simulation, anything better than 20% is considered excellent, and so we're really thrilled with these results. One of the things we've learned as we've tackled many of these complex patients, particularly many with heterotaxy, is that patients with systemic venous abnormalities undergoing a Fontan operation represent the highest risk cohort of having imbalance of both total flow and, importantly, hepatic venous return. This includes patients with bilateral SVCs, patients with interrupted IVC and azygous continuation. Some heterotaxy patients have an SVC on one side and IVC on the other side, and all of these are very high risk for Fontan completion. And what we've shown is that essentially if you have any systemic venous abnormality, you have, in our series, a 71% chance of having really disparate hepatic venous return, less than 15% to one lung, in many patients 0% to one lung, and everything else to the other lung. And of course that sets you up for pulmonary arterial venous malformations that result in progressive hypoxia and early death if untreated. So with CFD, we've been able to reverse this and in all patients achieve an acceptable balance, on average 36% to one lung. So this has been really phenomenal. I'll show you some examples of this. So this is a patient who has complex anatomy, interrupted IVC, azygous continuation, is a heterotaxy patient and needs to have a Fontan completion. And shown in the top panel of 4 images is the standard Fontan that we would have done had we not had this technology. And you can see here in the normal physiology, normal resting physiology, this child would have had 90% of their hepatic venous return to one lung and been at a high risk for developing AVMs in the left lung. But with flow simulation and various surgical plans, both simulated and evaluated, we were able to come up with a surgical strategy where we had 56% to the right lung and 44% to the left lung, and that child underwent that operation. And the post-op MRI showed that we were almost exactly on point. Here's another example of a patient who has a Fontan, and you can see in this upper panel their hepatic venous return is 100% to the right lung. They have clinical AVMs in the left lung and low saturations, and we're able to devise a plan, another heterotaxy patient with interrupted IVC, to reroute the blood from the liver back to the azygous vein, achieve really nice distribution of hepatic venous return, and did that in that patient, and they did very well, and their saturations have come up. And so, so this is a really challenging cohort of patients where just based upon clinical experience and intuition is not accurate enough, and really we found you really need to use this flow simulation. So one of the other things we've focused on recently is how do we use this to better understand how to manage Fontan patients as they get older. And what we recently showed is that when you get your Fontan and you're 2.5 or 3 or 4 years of age, your superior vena cava flow is twice your inferior vena cava flow. At the time you're 8, those flows are relatively equal, and when you're 15, your inferior vena cava flow is twice your SVC flow. And so you're going through a transition where when you put the Fontan in, it's relatively 4 times higher flow when you're a teenager. And in many patients, the current size of conduit we use or the changes in that conduit, or if you're a lateral tunnel, that doesn't always keep up. And what we're seeing is increased energy loss in these patients as they get older, particularly in that 8 to 15 year and older time frame. And so we're trying to understand, how do we use flow simulation, how do we use mathematical modeling in addition to our clinical tools to understand who's going to benefit from a Fontan upsizing. So we're seeing many patients who present with early liver disease and other evidence of Fontan failure, and lots of evidence that their Fontan conduit is not big enough. And so we're using flow simulation to really model what size of conduit brings that energy loss down in the Fontan pathway. And there's a sweet spot. If you make the conduit too big, you get more energy loss from sort of disrupted flow, but there's definitely a sweet spot. So we can use the same tool to show that. And we've seen this in a number of patients where we're seeing a sometimes dramatic energy loss reduction from upsizing the conduit. And often it's to 22 or 24 millimeters, which is way, way bigger, as you know, the cardiologists in the room know you would ever put in a child when they get their Fontan completion. And so I think there's a lot of learning that we have to do as a community about where that sweet spot is and how that needs to change over time. But I think we're going to be upsizing more Fontan conduits than we have in the past. And so in summary, we're using a clinical workflow with computational fluid dynamics in both primary Fontans and Fontan revisions. And we've shown excellent correlation between the predicted and post-op MRI measurements of the total flow to the lungs. And these flow simulations help predict how and when to do Fontan revisions to minimize late complications. And this computational fluid dynamics is really becoming an important tool, I would say an essential tool in these patients with really complex anatomy to plan their Fontan or their Fontan completion. And so we've done this by really growing a team of engineers at Boston Children's Hospital. So this effort started quite some time ago in 2016, and we got our first funding in 2017. And over time, we've added team member after team member, engineer after engineer to tackle all of these things. So we have a huge clinical service that makes these prospective 3D models for our patients. We're going to do 600 this year, and many of those patients have flow simulation or some degree of patch planning. So it's really enabled us to tackle these super complex cases and get really consistent results. And here's just a graph of how the 3D modeling program has grown over time. So it's really been a joy to apply these to these complex heterotaxy patients and really try to achieve a very predictable outcome. So going to shift from single ventricle to two ventricle repair, and this has really been a huge focus for our center for a very long time. And Pedro Del Nido and Ramamani started this effort 15 or more years ago, and for heterotaxy and non-heterotaxy patients. But really the rationale for doing this is that Fontans are fraught with challenges, right? So there's a number of complications that come from being a Fontan, and if it can be avoided, it's terrific to do so. So atrial arrhythmias are a common complication. Thromboembolism can happen from the conduit and the risk of a thrombus either in the lungs or going to the body. Protein losing enteropathy is another complication that we see in these patients with elevated pulmonary vascular resistance and other entities. You can have plastic bronchitis, which is super challenging and cilia-related complication. And then there's a decline in exercise capacity and an ongoing late mortality. And the overall survival of these patients still remains a challenge. And what we know is that some patients are less ideal Fontan candidates than others, and for those patients, we are really for all patients, but particularly for those patients, if you're a poor Fontan candidate and there's any way to achieve something other than a Fontan circulation, our motivation has been to do so. And risk factors that we see is, certainly single lung physiology and pulmonary hypertension are really challenging in a single ventricle circulation. Airway disease can be the same. Certainly some of these single ventricle patients are borderline patients have ventricular dysfunction, valvular dysfunction, pulmonary vein stenosis is a huge challenge, arrhythmias, heart block, and of course syndromes. Heterotaxy patients have historically been a much higher risk cohort for the Fontan operation and the Fontan circulation. And so a lot of motivation to do biventricular repairs to avoid some of these complications. Obviously not everybody can get a biv repair, but those who can, we do. So, so really the way we think about it is some patients have an adequate systemic ventricle, a left ventricle for the systemic work, and things like the left ventricular size, the aortic valve size, the mitral valve size within the normal range, Z-score of -2 or better, normal systolic function and normal diastolic function. And of course on the other end of the spectrum are patients who the left ventricle is just too small, the aortic mitral valve are too small, there's ventricular dysfunction or other lesions. But really the focus of our efforts are those patients in the middle, right? There's a huge number of patients in the middle where we can take steps to encourage growth of all of those necessary features, the left ventricle, the mitral valve, the aortic valve, and achieve a biventricular repair. And that's really what we focused on. So we think about this as sort of a borderline left heart or borderline systemic ventricle, and the options historically being single ventricle palliation or primary biventricular repair. But I think really the way we think about this is many of these patients are not candidates for a biventricular repair right away as one step, but they can be recruited to be ready for a biventricular repair through a series of steps. And I think that's where we really tried to approach this in a very systematic way to be able to apply this for those patients, particularly that I outlined are high risk for the single ventricle circulation. So it's really a heterogeneous mix of who are these patients in this sort of borderline biventricular repair category. Certainly patients with hypoplastic left heart syndrome and variations of that, small left-sided structures in general, known as a Schoen's complex, but a common group in the heterotaxy population are unbalanced AV canal defects in those patients. And so we really have applied strategies to each of these patients, sometimes differently, to achieve a biventricular repair. And so this is an example of an echo of a patient. I don't really have a pointer here. I'm going to see if I can do this without disrupting the slides. Oh, it's not showing up. Nevertheless, on your left in the lower portion of the echo, there's a small left ventricle that after staged recruitment and really forcing more blood flow through the mitral valve and into the left ventricle, we've seen growth of this left ventricle and now a candidate for a biventricular repair. And this is the paradigm which we work under for these patients. You can take steps to really recruit or grow a small left ventricle and really achieve a biv repair. And the question that we wrestle with every day, and Dr. Shidlow and I wrestle with all the time, and including this last week, is are you ready for that biv repair, or do you need further recruitment to do so? So one of the predictors that we have found is the left ventricular end diastolic volume. How big is that left ventricle in diastole? And that's been a strong predictor for patients who will tolerate that left ventricle being a systemic ventricle. If you're less than 30, that is a more challenging group than if it's higher than 30, and in other patients less than 45 is way more challenging than being over 45. And so that is one of the very important predictors that we use right now to understand, are you ready for a biventricular repair, or do you need some additional recruitment to get your left-sided volume to that level. Left ventricular end diastolic pressure, which we get by catheterization, is a very important predictor that we have shown. The cutoff that we found was about 13 millimeters mercury. It's a complex number that really speaks to both how thick the heart is. Sometimes there's a scar tissue lining of the heart called EFE, and all these add up to really being an important predictor of not only do you have volume, but does the heart relax enough to be able to handle the cardiac output on the left side. So left ventricular end diastolic pressure is one of the really important things that we look at for patients for biv repair. And another important factor is this scar tissue can get inside the ventricle, this EFE, which really typically forms when your aortic valve is small and the pressure inside the left ventricle is elevated, either in the womb or in the womb and after. And we now have approaches that we can actually surgically remove that scar tissue, sometimes more than once in patients, and that can really improve how well the heart relaxes. But those patients we've shown are a clear higher risk for biventricular conversion. So we have to take that into account and be careful about when we push those patients to biventricular repair, because they've been shown to be an important patient group that has definitely higher risk. So the unbalanced AV canal defects are really common, and it's a place where we've really been able to achieve a lot of growth of that smaller left side when that's the case. And so this is an echo example of a patient. The very skinny to your right structure in there is the left ventricle. You can see that's a long, skinny structure that is in no way ready to be a systemic ventricle. But what we've been able to do is take surgical strategies to both encourage blood flow through that left-sided AV valve and into the left ventricle, and also do some work sometimes on the valve to encourage the left ventricle to grow. We think about these patients: what is your volume of your left ventricle, and what is the architecture, particularly of your papillary muscles? If you have two well-spaced papillary muscles, that's encouraging. If you have a single papillary muscle, what we call a parachute valve, that's a higher risk group and often will need further recruitment. And so for many of these patients, we do take a step of closing the atrium, the atrial septal defect, with a patch and encourage that flow to the left ventricle. And our program led by Ron Monty recently created a video. Hopefully this is playing for you. Yep. So just sort of a highlight some of the steps. So, and this is an unbalanced AV canal patient who initially gets a stage 1 procedure or a Norwood procedure to get through the neonatal period. Then as an infant, typically in the 4 to 6 month range, we can close that atrial septum and leave the VSD open, and that will encourage blood flow into the left ventricle, encourage growth of the mitral valve, encourage growth of the left ventricle, and then over time, then can go back and do the full biventricular repair, which includes closure of the VSD with a patch, and then reconnecting the great vessels in normal fashion. The rest of the video is on the next page. So, so here's I got arrows on this one. So here's just an arrow showing the small left ventricle up there, and then after recruitment, you can see the same arrow on the left ventricle shows a much bigger left ventricle, and this is what we have seen over and over in these unbalanced canals. And here's the rest of the video. So this is the biventricular repair, where we reconnect the great vessels to their respective ventricles and then add a patch to close the VSD. So completely septate the heart into normal left and right sides, and then we have normal, essentially normal physiology of the heart. So this is really a huge focus for our group. And what we've seen is that we've been able to achieve growth in the left ventricle in diastolic volume, the left ventricle in systolic volume, and the LV stroke volume with these recruitment procedures. So patients who otherwise previously would have all gone down a single ventricle pathway, we now can recruit the left side, grow the left ventricle, grow the mitral valve, and achieve an adequate physiology for a biventricular circulation. What we've looked at recently is how well do these stage biventricular repair patients do compared to those who have adequate size, maybe surgical complexity, but adequate size out of the gate for a primary biventricular repair. They don't need that extra step to grow the left side, and what we've shown is the overall survival is the same. And so we've been able to really achieve the same final outcome in these patients. Yes, they have more operations, for sure they do. They need operations in the middle, sometimes 2 recruitment operations. And so it's an enormous commitment of the family to say we're going to go down this path. and take these extra steps, which always incur, essentially more upfront risk, sometimes more upfront surgery, but to achieve a biventricular circulation rather than a Fontan circulation. And this is one of the challenges that we face both as clinicians and the families face commonly when we look at these kind of scenarios. We looked at our patients in comparing patients who've had a biventricular repair versus single ventricle palliation, and obviously these are very heterogeneous patients. It's tough to line them up in exact groups, but overall, as we all would have expected, the biventricular repair patients do better in the long term than the single ventricle palliation patients. So I think our motivation continues to be to recruit these patients for biventricular repair when it's feasible. And just some more data. This has actually been submitted for publication. This is really a matched, as well matched of a group as we can, which shows lower risk of liver dysfunction and better overall outcomes for biventricular repair patients. So we'll continue to push that. I'm going to share with you now just a couple ways that we're using 3D modeling and virtual surgery to really plan and conduct how we do these complex biventricular repairs. I apologize, I had to step out this morning of the session because Dr. Shidlow and I have a patient we're doing this coming week, and we're actually in the middle of planning 2 elements, both of which I'll show you, not this patient, but this has really become an important thrust of our program and the 3D modeling and engineering team that I run. So this is a patient with heterotaxy who needs both an atrial level switch and also needs to baffle the left ventricle over to the aorta to achieve a biventricular repair. They have a double outlet right ventricle and they need an atrial level switch. And so if we look inside the heart, the teal is the right atrium, soon to be the left atrium. Inside the orange is the left ventricle. And as this video runs, I'll let it play through again. You're sort of looking up from the end of the heart in the left ventricle, and you can see the pathway to get the left ventricle flow over to the aorta in the red. You can see that pathway that exists there, but you need a patch that will redirect that blood flow from the left ventricle over to the aorta. That patch has to run right above the tricuspid valve, right below the pulmonary valve, and where the flow goes up to the pulmonary valve. And it has to not injure the conduction system, which Lizzie DeWitt will talk about soon, how we do that, and also can't injure the aortic valve. It just has to be perfect. And so what we're able to do now is to plan these patches beforehand. And one of the challenges in these patients is you don't always have the best visualization. You can't just open the whole thing up like it looks here and see everything perfectly. And so sometimes making those intraoperative judgments about, I should trim the patch a little bit, I should make it a little bit bigger, those can be really hard in some of these patients. And so you can see here in this green patch, we're able to plan where that patch goes and position it so it's going to be just the right size and attached in just the right spot, and do all that before we go into the operating room. You can see how that is positioned to just avoid all the critical things. And then we faced as engineers, okay, we can plan this beautiful patch. It looks like a Pringle. How do we get that into the surgeon's hands, right? And so, it's one thing to visualize it and say, oh, this is where the patch should go. It's another thing to have that to the millimeter. And so one of the challenges is all of our patch materials are flat and all of the patches are curved. And so in order to get that correctly done, there's a complex mathematical algorithm to achieve the flat patch equivalent, if you will. So when you trace it out on that flat patch and sew it in and it pressurizes, it'll achieve that curvature that you need. Otherwise, if you do it wrong, it'll buckle, it'll kink. And everybody who takes care of congenital heart patients have dealt with those issues in the past, and it's just physics, right? But if you take into account the material properties of the patch and of the heart, you can achieve that. And so our engineering team has developed all these algorithms to do that. We use some aerospace software to get it done. And now we have another aerospace trick. We have a laser system that's used in aircraft manufacturing that's now in our operating room. And so we can take the patch design and we upload the design to the laser. The laser projects the design onto the sterile patch material. It's like the world's most expensive laser pointer. And you trace it out and cut it out, and we showed that we have less than 2% error between the patch design on the computer and the cutout patch in the patch material. And so it doesn't matter what patch material you want to use, the laser will project onto anything. You trace it out and you cut it out and sew it in. So it's really, as you can imagine, totally transformed how we've done these complex repairs. And so there's no more, I'm going to make this up in the OR, I hope it goes okay, I think I can get it there, I think it's going to be fine. We try to eliminate all that we know we're going to have a plan, we know it's going to work, and we know it's going to be the right shape and size. And so this is another common challenge that we face in heterotaxy patients is their systemic venous connections, their pulmonary venous connections, and their atria are all mixed up. And you heard it all morning how there's so much heterogeneity in these patients in their atrial anatomy. And yet when we're trying to achieve the biventricular repair, we got to get the atrial flow to the right ventricle. And sometimes it's really quite challenging. And so what we've learned is we can also plan these things out, just like we plan the VSD patches out. And that's what I was doing this morning, is planning a complex mustard in a heterotaxy patient. And so this is really an effort to be able to baffle any venous structure from one side to the other. And sometimes we have to do a formal atrial switch, like a standard SLL, L transposition. But in these heterotaxy patients, it's usually it's a whole mix of things, and sometimes you're baffling just the SBC or just the IVC or both. They're various things, and the atrial structure is very, very different. So what we've learned is just a very patient-specific patch planning workflow is the only way to do this. And so this patient has a left superior vena cava, and I don't have a pointer, but shown here on the right side of your screen is the superior vena cava going on top of the pink left atrium, and we essentially have to baffle that over to the right atria. And now what we're able to do is to plan, both plan that pathway, as you can see, and plan that exact size of that baffle, and then plan the patch structure on the inside. We take that plan in the operating room, put it up to laser, project it down on the curved patch material, trace it out, cut it out, sew it in. We've done this down to 4.5 kilo patients, which in the past we never, ever, ever would have tackled. We always waited till they were 7, 8, 9 kilos. And now with this, we have confidence that we can do it in smaller patients. And really, it's been a game changer. So, and one last really super impactful area that we've tackled, these complex AV valves. You heard how common valve disease is in our heterotaxy patients. In many of our patients, they have complex AV canals and present either as single ventricle patients or biventricular repair patients, and repairing the valves is an essential component of achieving a biventricular repair or achieving an adequate Fontan circulation. And so we have a program now. We can make exquisite 3D models of these AV valves, spearheaded by a cardiologist, Reena Ghosh, who's on our team. And we've used this both to understand the structure of the valve and then also to plan the exact interventions. And you can see we're able to model both the leaflets as well as the chordal structures, as well as the papillary muscles, and we're able to put dimensions on all of that. So I'm sure you can appreciate it, as an engineer, I want to go to the OR with a plan, right? A plan to the millimeter, and we're able to now do that with these 3D models. So it's really been super impactful for some of our most complex patients, and something we're looking to expand a lot in the future. So just a little taste of what we're doing from the surgical standpoint for heterotaxy patients, but it's been a joy to partner with Dave Shidlow and the expansion of the program, and really try to, add some more consistency to how we approach these patients surgically, and look forward to taking any questions later in the session.